It's Anonymous MD with Dr. T.
And Lisa.
Dr. T brings the real and refreshing insights, straightforward, evidence-based, and up-to-date. Now here's the doctor and Lisa.
Unbreak my heart, say you love me again.
I don't know who you're pleading to, but you're going to have to work harder probably.
Yeah, I'm going to stop now.
Yep.
I think I'll stop at this point.
Right. Well, hi, everyone. You know, that was
Welcome
a good
back.
wake up at the beginning of this podcast, wasn't it?
Yeah, well, the reason why I decided to lead in that way is because we are so excited to have a cardiologist, Dr. Mark Fisher, join us today to give us the COVID-19 perspective from the brain of a cardiologist.
The official unheartbreaker. Here it is. Good stuff.
Yeah,
Welcome, Dr. Fisher.
So quick housekeeping. We're going to do, so let's just say there are about, as of today, 3.6 million recorded cases of COVID-19 around the world, about 250,000 deaths. But we say this every week. Those statistics don't matter because really the testing isn't adequate enough. And because of that, we can't really use those numbers. So let's get relative and let's compare to something else. And I think it's pertinent to compare to death from cardiovascular disease, meaning heart attacks and strokes. So about 18 million people die from cardiovascular disease a year, which accounts for almost 1/3 of all deaths around the world. So without further ado, I'd like to introduce Dr. Mark Fisher. Thank you so much for joining us.
My pleasure. Thanks for having me. It's delightful to chat with you guys. I've started listening to the podcast recently and very good information. So I'm happy to say something.
Yeah. And really what we're trying to do is we're trying to minimize the hysteria and try and stay rational in terms of our thought and thereby guide our decisions in a way that's rational as well. I'd just like to go ahead and introduce, your credentials. You work in Toronto. You've been at St. Joseph's Health Center, which is a wonderful hospital for the past 20 years. And you were actually the chief of cardiology there for 10 years. You also do interventional cardiology, which means that you do angiograms, not doing them so much these days, I guess, if they're elective because of COVID-19. But you're affiliated with the University of Toronto Department of Medicine, and you run your own practice at Riverside Cardiology. And I can just tell the listeners right now that from working with you, your work is exceptional. So we have a great guest here today, folks.
Thank you. I guess the only conflict of interest is, yes, I know you're the anonymous doctor, but I have worked with you, and so obviously I know you guys and your practice, and
That's okay. If you slip up, we'll bleep it out. Don't worry about it.
It's been a pleasure to work with you going forward. Thank you, Lisa. Just the other disclaimer I should say. So I'm happy to chat. These are my own opinions. I'm not speaking as officially representing St. Joseph's or the university.
Right.
Yeah.
Very important to disclaim that. Although, as we move ahead, I think we'll keep it kind of safe here with how we question you. How does that sound?
No, I'm happy to give my opinion, and it's an interesting discussion.
I would also like to just jump in and say that I do represent all women when I speak. So
okay. Good.
Yeah. And men and dogs and every living creature, right, Lisa?
Right. Yeah.
Isn't that right? So why don't we start with this question? Let's go general. So Dr. Fisher, overall, if you had a message that you wanted our listeners to hear from a cardiologist during this COVID-19 era, what would that be?
So I guess the message, I'll give a bit of a longer answer if that's okay.
Please.
And the message pertains to that, but we saw COVID coming to a certain extent, and as it got closer and things were happening in Europe and Asia, the hospitals in general were getting very prepared for this flood of patients and surge. And fortunately, at least locally, I think we were fairly well prepared. What surprised us, a lot of the physicians I've discussed this with, and in particular with my colleagues, cardiologists, is that obviously we have seen COVID, a fair number of COVID patients, but the non-COVID patients coming into the hospital or health center, we've seen fairly dramatic reductions. So whether we're talking about heart attack patients, stroke patients, patients coming in with other medical conditions, serious conditions where they may need to potentially have surgery or be seen by a specialist, if you speak to the emerge docs, the numbers are down. And amongst my colleagues, and not just locally, but there have been a number of papers looking at what happened to all the heart attacks. And so this surprised us, frankly. And we did share one of the papers, and there's been quite a few looking at this in various countries. And so, for example, STEMIs, we talk about STEMIs, ST elevation MI, or STEMI for short, sort of the classic heart attack where one of the heart arteries blocks suddenly. And
the worst kind.
The worst kind, the serious kind where we talk about time is muscle. So the sooner you open up the artery, the better, and you prevent damage to your heart muscle. And these are where the public service announcements: call 911 if you're having chest pain, don't delay. And we have these programs set up where if you have that situation, the paramedics do an ECG, a heart tracing with the electrodes, and if it shows the STEMI, you go directly to what's known as the cardiac cath lab, where they do an angiogram and hopefully open up the blockage. And that's important. And so those STEMIs are way down, and depending which study you look at, which country, but in the range of 40 to 60% reduction. And so we've noticed this, and it's so on one hand, you could say that's great news. People are having less heart attacks, less strokes. Maybe that's the good side of COVID. But the concern amongst us has been, it may not make that much logical sense there'd be a 50% reduction in heart attacks or strokes or other serious things. And are these patients, we can discuss why that may be, but our big concern is, are patients scared to come to the hospital?
Well, I can tell you from a family practice perspective, since this COVID-19 pandemic has started, we're definitely getting more resistance when we're calling on patients to visit the ER. We talk about STEMIs and how time is muscle. And if we just go to neurology real quick, time is also brain neurons as well. When we deal with strokes, we have a certain amount of time in which we have to deliver particular kinds of medication to stop the blockages in the brain as well. But Dr. Fisher, can you give us an idea of what kind of time frame we're talking about? Is it minutes, hours, days?
Yeah, I absolutely. Just to finish with the message, so I can go say this again later, but just so the main take-home message, I guess, we want to make sure that patients who are listening to this, healthcare people should know this, but for patients, if you're having the symptoms of a heart attack or a stroke, don't be scared to call 911 and to get it looked after. And frankly, if you're having abdominal pain, and you may have appendicitis, don't be scared to get it checked out. That the hospital, even though there are COVID patients, it's a safe place. There's a lot of safeguards to prevent you from catching it. And I guess, I'd like to say that if you think you may have a serious situation, the risks of catching COVID and getting very sick are extremely low by going to the emergency and getting assessed, compared to the potential downside if you stay at home and suffer. So okay, sorry, I can talk then about the time with the stroke and heart attack if
please go ahead. We'd love to get as much information as we can from you today.
And so to follow up on your second question, the concern is, frankly, whether it's a heart attack or a stroke, minutes actually matter. especially for these STEMIs, which is the sort of acute, serious heart attack where the artery is blocked. And for stroke, absolutely it's a matter of, minutes to, if you have a window with stroke, for example, there's these blood clot dissolvers that we use, which are powerful and do make a difference. And you've got a window there of 3 to 4 hours. And if you come later than that, that treatment likely won't be an option. And we're talking about the difference between having an excellent recovery from the stroke, versus being left with this significant disability, which is not just going to affect you, but your loved ones looking after you. And as I say, sort of minutes to hours is a time frame. So, just now this is anecdotally, we've seen cases come in late. I was reading one surgeon's account that someone who sat on their appendicitis at home and got fevers and severe abdominal pains, and finally came in days later when they had a large abscess in the abdomen, which, if they had come in earlier, could have been dealt with as a routine case, became almost, a nightmare to deal with. So this message is, don't be afraid to seek medical attention when you need it.
And I'll just add to that, when we get calls to our clinic and patients describe concerns for contracting the coronavirus itself, as long as they're not reporting chest pain or shortness of breath or dizziness or concerning symptoms, we're not sending them to the ER or the emergency department. We're sending them to specialized COVID-19 testing centers.
Right.
So that's just to add some, an additional perspective from a family doctor, that we're also kind of triaging in a way to prevent patients who have COVID-19 from going to emergency rooms.
Good point. I mean, I guess the emergency with the non-COVID stuff is seeing less patients, and perhaps, some of those are appropriate, that they probably are, that they're not going when they shouldn't go to the emerg in the first place. I mean, my concern is the ones who should be going that aren't. But you're absolutely right.
Right. I think it's really important to point out to people that the hospitals are doing a great job of making that division, Dr. T, like you mentioned. So if you're going to get tested for COVID and for possibly having COVID, you're not going into the ER. And I know that is the main access point that everyone imagines they will be going to if they access the hospital for COVID, but it's not. And so if you are having any sort of chest pain and non-COVID related symptoms, know that the ER is probably less of an infectious place and less contagious place than it normally is. So if anything,
like your own
right
home.
Now is a great time to go to the hospital if you really need to. It's a good time to go.
And the wait times are probably down too. Now again, that's anecdotal, but
that's what I'm seeing. Yes,
that's what we're seeing, right? So, please, you
all we have is anecdotes right now. Anyway,
that's right. You're absolutely right. This hasn't been around long enough.
No. So, Dr. Fisher, my question is, if you're just to give some more context to people, because I think, how many people would you normally see if you're doing an ER shift, or if you're on call at the hospital, coming in with heart attack on a regular basis?
Well, it was, so it's interesting. When the first shift, I was on back at the hospital after this started, was much quieter than usual. We typically do 7 days on call. Because we were a bit concerned about how things would go with COVID, we changed it to a 4-day shift at a time. But never, so typically on one of those average days, we may get between 7 and 12 new referrals, new consults, people with various chest pain, shortness of breath, arrhythmias. And then over the course of the week, some of those patients will be under us as a cardiologist. We'll be looking after them, and some will be consults. But it's usually a quite busy week. When I came on, the sign over for my colleague who was signing over to me, he had 0 patients to sign over. And
oh my, unprecedented.
Wow.
And this is exactly, it is unprecedented. And I did a double take and emailed him, said, "Are you sure?" And he said, "Yeah, there's nobody." Now, it's not to say there wasn't some of the patients who come in with chest pain have other issues and they're under our general medical service. But the ones who are primarily cardiac, we take over. And he had 0 to sign over. So this is the magnitude. It was like, what? And those next 4 days that I was on, we're seeing a handful of consults, but it was dramatically lower. My last 4-day shift, which just ended doing the hospital work, it has started to pick up a bit. So already, again, this is my local anecdotal experience, but we are starting to see it get a bit busier. Now, keeping in mind, most hospitals have shut down all the elective surgery. So some of the business would be patients who have complications after surgery, and most of that surgery has stopped. But nevertheless,
and pre-operative, I assume too, right? Dr. So pre-op assessments to make sure that they're safe for that type of surgery. You're probably not seeing as much.
Exactly. But just the person who goes to emerge because they have symptoms, it was quite a surprising drop. So that's where
I did not expect the numbers to be that different.
That's just my.
I'm so glad I did. Oh my
goodness. Yeah, that was my case. I mean, that was dramatic. But when you look at the different reports from different countries, as I say, they're saying 40 to 60% less heart attacks, strokes, and I just add the concern we have is we talk about the second surge with COVID. If what we're fearing is that there's a number of patients who are staying home, having their heart attack, and then either, some of them could die, but some will have damage to the heart muscle and then end up with complications days to weeks later, is there going to be a surge in the next little while of people coming in with what's called congestive heart failure because their pump function has dropped? Are there going to be, late stroke patients coming in disabled? I mean, God forbid, we hope not, but this is sort of
well, you're really talking about what the repercussions could be of this current fear of the emergency room visit.
Exactly.
Yeah. And those are chronic conditions, right? That really affect the healthcare system. So
exactly.
I think that's a really good way to transition to what I wanted to ask about, but I think our listeners are really, really going to benefit from, and that is, what are the lifestyle changes? What can we be doing while we are, sitting on our tukuses at home? What can we be doing? Tell us.
Yes. I mean, generally cardiologists and family doctors as well. And I mean, most healthcare people do know about the healthy lifestyle and promote it. And I mean, we do that every day. It's an interesting time. I mean, it's obviously an unfortunate situation, a terrible situation with COVID, but it's interesting from that standpoint is that, you guys have talked about this on the show, there is an opportunity here. So obviously this is just devastating, especially for, certain places like nursing homes. But what is the opportunity here? That things are obviously going to change. And so what we find is there are some patients who buy into all the lifestyle things and no problem, but majority of people, it's hard to convince them. And the, heart disease, stroke, they're sort of these, they creep up on you over the years. And the way most humans think, we're designed to, fight or flight and react to an immediate threat. But when you talk about lifetime risk, it's sometimes hard to convince people. So the opportunity here is these lifestyle modifications, which I'll just lay out in a second, probably are helpful to the immune system. And so people sitting at home terrified about COVID, catching it or giving it to somebody who's at risk, and the talk is, well, what can I do to help my immune system? A lot of the things they are common sense, but it's an opportunity to help your immune system in the very short term. And hopefully, if you do get sick with COVID, this will help you have a better outcome, a faster recovery. And as well, if you can adopt it now and keep it going, it can turn into give you cardiovascular protection in the long run. And so that's where I see an opportunity. I mean, I will say I'm as guilty as the next person. It was very tempting in the early phases of this to binge watch Netflix, stay up late, not get enough sleep. and overindulge in food or alcohol or both.
You mean you're human? You mean you're human, Dr. Fisher?
Absolutely. Don't.
Doctors aren't human, guys. Stop it.
No, we're not robots. We are not robots, Lee.
I mean, but do as I say, not as I do, right? But so the lifestyle things which we promote, and I'm sure you guys have promoted before, and I'm sure Dr. T does it all the time. And again, it's not rocket science, but not smoking, drinking alcohol in moderation, if at all, not overindulging. Food, I'm a big proponent of the healthy Mediterranean diet, and frankly, vegetarian diet is fine too. That's hard for a lot of people to adopt, and I find a lot of my patients, the Mediterranean diet is a little bit easier to go with in the long run. But the Mediterranean diet, and I won't go into too much detail on that.
And folks, this is all evidence-based, by the way, when we talk about these things. Now we're getting into stuff where there's some evidence and strong evidence behind it. So, exactly. One thing that Dr. Fish and I have always agreed on and is the Mediterranean diet would be the way to go. Quitting smoking, exercise, that goes without saying. Any other tips?
Yeah, being active, and even if you haven't been active, start small steps are important. And I tell patients, don't get discouraged if you start exercising. Even if your weight doesn't change right away, you're still doing beneficial things. And there's lots of literature on doing the exercise. There's hormones that are released. There's changes that happen to your arteries, your blood vessels. And it's been a lot of things that happen even before the weight starts coming off. So don't be discouraged. But being active, and we talk about doing 20 or 30 minutes of sort of cardio exercise at least 3 times a week if possible, and weights have benefit as well. So the activity, getting enough sleep, and I especially think physicians are guilty of this, not getting enough sleep, and the binge watching doesn't help that. But there is evidence that getting enough sleep and dealing with your sort of mental health is helpful to your immune system as well as in the long run.
Yeah, and just to add to the sleep, I'm not sure which studies you've seen. I saw a great study. They actually studied residents, and they compared the residents who were in elective rotations that weren't as rigorous versus those who are in the hospital and much more rigorous. And they kind of found the magic number there was 7 hours of sleep. So, if you get 7 or above, there's not much difference between 7, 8, 9. But once you're below 7 hours of sleep, I think it makes a difference. And I'll just add one more thing, Dr. Fisher, if you don't mind. Also, I'm seeing some pretty good data about the intermittent fast diet. But I think the proponents of it, they advocate for an overnight fast. I actually believe more in a protein-rich, low-calorie breakfast, and then actually a daytime fast until you hit dinner, at which time you can start to target that Mediterranean diet. So those are a couple of my tidbits as well.
Good point.
That's great. It's just such helpful information. And I wonder if, because this is, a respiratory illness, maybe more people will quit smoking during this time. I don't know. I mean, people are stressed out, and smokers love to say that they can't quit smoking because they're stressed out. But it might happen because it is sort of the closest that smokers will have to having an immediate negative reaction if they get COVID, right? As opposed to cancer, same thing with heart attack, stroke. They're so long tail.
Yeah, that's interesting.
I don't know. Maybe the psychology of it will turn a switch for some people. Hopefully,
I would like to hope so. That's very interesting. I mean, on just the argument to that is that during stressful times and when you're cooped up with family, potentially in a small apartment, getting on each other's nerves, reading news every day.
Right.
It may be hard time to quit, but I think some patients, you're right.
That's right. I mean, it's a logical time to quit. Not that addiction is the most logical thing, but that's wonderful. So I think what we're learning today is that if you're having heart attack symptoms or stroke symptoms, and we know what they are. I mean,
Is
We've
it worth
been having
just
PSAs
listing them?
forever. Yeah, absolutely. List them, please.
I mean, just touching on that and this information is widely available on the internet. And most people know this, but just to briefly touch on, if there's severe chest discomfort, it may not be in the chest. It may be in one shoulder, the other shoulder, the arms, up into the throat, even severe sort of stomach, or we call it epigastric discomfort, the upper abdomen, especially if there's profuse sweating or nausea or vomiting or just feeling faint. I think that you have to pay attention to for the heart attack side of it. And then for the stroke, a sudden onset of new symptom, of numbness or weakness, your arm isn't working, or it feels like it's frozen or asleep, or you can't speak, or your facial drooping. I'm probably missing something.
Don't waste time, folks. Just get there. You know what we'll do? Exactly. At the Real Anonymous MD, I'll find some pictures that'll kind of go through these symptoms, and we'll put them up there for our listeners just to kind of reinforce the message there. And
I would like to say, so, and it's a natural thing. Patients say, oh my God, I don't want to call 911. I'll feel stupid if it turns out to be indigestion. And I get it. It's a natural sort of fear. We're Canadians. We don't want to abuse the healthcare system, but honestly, it's much better to check it out. And if you're concerned, we'd rather, rule it out and reassure you. And like you said, Dr. T, the emergency at the moment is not, it can handle the business. If you need to get it checked out, better to be safe.
And that message is for family doctors as well, because when we send patients to the emergency room too, we don't want our colleagues to become overburdened with things that aren't really an issue, but we have to err on the side of caution. And in our practice, that's what we're trained to do as generalists. So patients should follow that same lead.
Yeah.
And I have to say, as a specialist, a family physician or general practitioner, it's not an easy job. And sometimes specialists may see things differently, but as a family physician, you're trying to sort out many patients with many symptoms, have a lot of respect for that. And if a family physician's concerned, it's better to be safe than sorry. And so I hear what you're saying, and
what a wonderful episode,
guys. Don't be embarrassed. Your friendly neighborhood cardiologist is lonely at the hospital. Love to see you if you're having.
Didn't say that.
Okay.
Lise, you want to give us a little summary of our amazing episode today, or what?
I think what we're looking at, other than our anecdotal stuff, which is always my favorite part, we know that, but is that there's a 40 to 60% decrease in certain areas that have done this sort of data gathering in heart attack and stroke symptoms coming into ERs. And that I think we can all assume that the 40 to 60% isn't because of extreme, amazing lifestyle changes that happened overnight, and that people are preventing themselves from going into the ER out of fear of COVID. And that is not a fear that is based in evidence. Dr. T gave us the percentage that over 30% of annual deaths are from cardiovascular events. And the percentage of COVID deaths, although we don't have the exact number, is going to be nowhere near that. So what you're really at risk at is dying from a heart attack.
And from suffering from the chronic conditions of the heart attacks or strokes that don't end up killing you. So
exactly right.
Dr. Fisher,
get to the ER.
Get to the ER. Dr. Fisher, are there any final messages you'd like to have our listeners hear before we sign off here?
No, that was I think a good summary. I'm not sure there's anything else to add. If either of you have any last questions, we could talk.
I just want to say it was such a pleasure having you on. We feel so just honored and privileged that you take the time to come on and speak to our listeners and continue this campaign of rational thought. And,
yes.
And that's really the idea. Next week, we're going to have Dr. Dacre Knight from the Mayo Clinic, and he's an internist. So he's going to come on and speak to us about his main messages he'd like to get across. And folks, we hope to see you next week. This continues on longer than we anticipated, but for good reason, I think.
Yes, thank you, Dr. Fisher. And remember to find us wherever you listen and to follow, subscribe, and ring that bell to get the notifications when we have a new episode on YouTube.
At The Real Anonymous MD. I'm going to put up the signs and symptoms of heart attack and stroke for our followers and listeners. See you next time.
See you soon.
Thanks for listening to the show. Subscribe wherever you're listening to the podcast. On YouTube, smash that bell. That's a notification button. Anytime the doctor knows something, so will you. Stay healthy. See you next time.